All right, so just a little bit about the motivation behind my research. It really came down to seeing the impact that COVID-19 has had and is still having on the public health throughout the world. As we know, economic and epidemiological research is vital to bolster the economy and maintain human life worldwide. And as we know, nations have implemented lockdowns intent on slowing the spread of the virus. And one thing that I feel like generally seems to be an area of discussion is lockdown in general, like too much lockdown, too little lockdown. It's affecting the economy, something that people don't really tend to agree on across the board. And so with that in mind, I wanted to see if I could use some mathematics to model lockdowns through the pandemic, through the COVID-19 pandemic. Some of the goals I had in mind when conducting my research, I wanted to be able to examine how parameters such as fatalities and, such as lockdown intensity and public compliance could be adjusted to observe how a nation fatalities, the outcome of a nation's fatalities from COVID-19. With that in mind, the main objective of this research was to take a disease model and incorporate further parameters to simulate a model. I'm hoping to use this model to provide insight to the importance of lockdown intensity for the future. All right, since this is a model and it's not real life, I obviously have to make some assumptions. And so the first assumption I'll be making is that in any lockdown level, we can guarantee that not 100% of the population is going to comply with that. So that's kind of a given. I feel like we can all probably agree on that. For my model, I'm assuming that a max lockdown will be at 70%, and that's just to account for 30% of the population being essential workers, which seems reasonable. When I started this research, vaccines weren't really readily available. So for that, I will not be using a vaccine parameter throughout my model. And another thing that I'm assuming is that once someone's recovered from COVID-19, they can't be reinfected, which would be nice in real life, but unfortunately that's not the case. But in the world of my model, that's something that I will be assuming. So some of the methods to model the spread of COVID-19, I'm using what's called a compartmental susceptible infected recovered model, generally referred to as an SIR model. A deceased group was added, making it an SIRD model. And we can kind of see the flow of the model here. As individuals move from susceptible to infected, they can only move into either recovered or a deceased group. And the SIRD model is depicted as a system of differential equations. All right, I know this looks kind of scary for some of you, but bear with me. This system of differential equations is just the model of the spread of the disease under lockdown. And beta in this case is set to 0.2 and gamma is set to 1/18 to account for an 18-day recovery. These parameters were taken from similar papers when I was conducting most of my research. There might be papers using slightly different parameters, but this seemed to be common numbers when I was beginning to do this. L is dependent on time and is the population percentage under lockdown. And again, I said that would be between 0 and 70% throughout my model. Theta is the obedience level of the lockdown. I have adjusted that in my research quite a bit to look at different outcomes under different obedience levels. But for sake of time and in this presentation, I will be assuming theta is 50%. So across the board, 50% of our population is abiding by the lockdown. And phi is a death rate function that is dependent on the infected number. And I won't go too far into that. That's kind of a cool little function that I added in that kind of is determined by like hospitals being overcrowded. But yeah, pretty cool. So if you notice, theta is being multiplied against, if you look up in the susceptible population up top, is getting multiplied against our lockdown. So that gives us the amount of people that are actually obeying the lockdown. And 1 minus that is the amount of people that are not obeying the lockdown. And I'm multiplying that by our susceptible and infected population. And if I lost you there, that's okay. Just a little bit of background on how that is working right there. So awesome. So I solved this system of differential equations using software. There we go. Software MATLAB. And I simulated it over a 365-day period. our lockdown parameter is set to 0% in this case. And for those of you who aren't familiar with SIR models and how they work graphically, our susceptible population is the blue line right there. And if anybody's colorblind, I apologize. The susceptible population is the blue line, and it's starting at 100% and it's moving down as individuals move into the infected population. And we see that the recovered population after the 365-day period is almost the full population with a few casualties, unfortunately. And this is, with this outcome of zero lockdown, we see a max infected of 36.2% of the population. And we end up with only 2% deceased. Might not seem like a lot, but there were 100 people in a room and 2 of them ended up dying to COVID. Well, it's kind of a big deal if you put it in that perspective. So next, using the same model, if we set the lockdown level to, oops, nope. I apologize. I uploaded the wrong PowerPoint on accident. There's a couple mistakes that I fixed. Okay, well, we'll just skip that. So if the lockdown parameter was set to 70%, we'd actually end up getting about 0.73 deceased. And this is actually not the wrong plot for this information, so I apologize. Again, I uploaded this really quick and I got the wrong one. So, but the cool thing about this is we see a small flattening of the curve, of that infected curve. And when you hear people talk about flattening the curve, this is generally what they're referring to. So yeah, definitely a huge change from the 0% we had earlier. I had some more slides showing like 35% lockdown. I apologize that I don't have those in here, but that's kind of how the dynamics of that model are working out under lockdown. This was supposed to be the 70% slide. So we see a definite flattening of that curve over time with more lockdown. All right, so the next step was to create a cost equation. I'm still working on this currently. And the goal of this cost equation is to minimize current costs brought on by COVID-19 per person during a lockdown. And R represents the annual discount rate. This would be in GDP. So if each person produces an amount of GDP, omega represents that unit output per person. And yeah, I plan to continue working on this problem in the future. All right, so this model shows how a pandemic lockdown can develop over a 1-year period. Compliance from a population is obviously vital to keep the disease levels low. And there's no way of knowing the obedience level of a given population, but I've been also doing other things with this research and kind of just investigating obedience levels and how that changes the outcome of the lockdown. And I plan to keep observing how high the obedience levels in a population produce shorter lockdowns. But yeah, that is pretty much my research in a nutshell that I've been working on over the last year. Thank you guys so much for coming out. And I apologize for some of the technical difficulties, but if you have any questions, let me know. I'll be here. That's it.
Thank you guys for your patience. So again, my name is Chicena Mortimer. I'm a first-year graduate student in the Integrative Human Physiology Master's Program. And my faculty mentor for this presentation and for this study is Dr. Freire. And I'll be discussing a follow-up analysis on adult patients with mild to moderate COVID symptoms after immunization. So just some background, we know that COVID is a viral infection that attacks the respiratory tract, and it's highly contagious, and it's so contagious that over 5 million people have had cases of COVID, resulting in over 6 million deaths. And because this study was done in Brazil, it's also important to highlight that there were over 30 million cases of COVID in Brazil, resulting in over 665,000 deaths. So when we're researching COVID and finding these novel data regarding the effects of COVID, a lot of that focus is put on individuals with who are in the older population, those who've experienced severe symptoms of COVID. And so there's like a lacking of research in populations that are on the younger side, also experiencing mild to moderate COVID symptoms. So these people are commonly overlooked in research. And so it's also important to highlight that while we're researching the effects of COVID in these mild to moderate, people experiencing mild to moderate COVID symptoms, that they experience persistent symptoms, including like headaches or mood swings or memory loss. And so the aim of this study is to kind of follow up on those people who are young individuals, relatively young individuals experiencing mild to moderate COVID symptoms, and to see the effects of vaccination in these populations. So here is the study design for this study or this research. There was about 57 Brazilian inhabitants that performed the study, male and females. They range from 20 to 40 years of age. And I'll come back to this slide. So this study was approved, or the individuals of the study underwent informed consent, and it was approved by the Ethical Review Board. We gathered 3 parameters in question. So those were a clinical questionnaire, an MRC data, MRC dyspnea scale to quantify any respiratory distress, and pulmonary function and cardiovascular function. And so just to kind of show you guys what the dyspnea questionnaire looks like, it's like a one ranging from 1 to 4, 0 being having no difficulty breathing except for doing strenuous tasks, and then a 4 would be difficulty breathing during normal ADLs or activity of daily lives. Additionally, blood pressure was taken using a sphygmomanometer and a manual stethoscope to gather systolic and diastolic blood pressure, and respiratory or breathing frequencies was assessed just by visually looking at the inhalation and exhalation of the chest cavity. So back to this. So after these groups were gathered, they were put into 2 categories, one being the COVID group and the control group. So the COVID group at baseline was taken after about 14 to 120 days of testing positive for COVID using a PCR COVID test. And baseline data for them was taken before vaccination. 6 weeks after vaccination, they came back again, and we took the same data for the COVID group, and for the control group, they tested negative for COVID using a PCR COVID test as well. So here, figure 2 shows blood pressure in these populations. And so we're seeing here on the first, I guess on the leftmost or rightmost, however you vision it, this is the COVID group. And then the COVID group follow-up is right next to that. And then we have the control group and the control group at follow-up, and with systolic blood pressure being on the y-axis. And so here we can see differences between and within groups from baseline to follow-up, and then between COVID group and control groups. And so we can see no significant difference between systolic blood pressure and in this population for this test. And then, sorry about that. And then for diastolic blood pressure, again, with the same groups being on the x-axis, we're seeing diastolic blood pressure being on the y-axis. Again, no significant difference between and within groups from baseline and follow-up for diastolic blood pressure. And again, just to highlight, this data was done as a descriptive analysis. So we're just using mean and standard deviations to quantify significance. And here, again, breathing frequency with the same groups on the x-axis, and then breathing frequency was taken as breaths per minute on the y-axis. Again, showing no significant difference between and within groups from baseline and follow-up. Finally, the MRC scale assessing dyspnea was taken, same groups on the x-axis. So you guys are going to be really familiar with this x-axis by the time I'm done with this presentation. And we see dyspnea score, again, ranging from 0 to, normally rating from 0 to 4, but we just went to 2 for this on this chart. And again, using mean and standard deviations for quantifying significance. So some strengths and weaknesses of this study. Some strengths were that this is relatively one of the first studies to present data regarding those individuals who are a young population. Again, the study was done in individuals ranging from 20 to 40 years of age. Additionally, this is also a novel research regarding individuals who experience mild to moderate COVID symptoms post-vaccination. Some limitations to the study, I'll them both up, is that there was a high drop in participants for follow-up data. We started with 57, and more than half didn't come back for follow-up data analysis. And again, this was a descriptive analysis that was done, so we're still awaiting statistical analyses to understand true significance between these populations. So in conclusion, after immunization, levels of dyspnea were relatively similar between both COVID group and non-COVID group and control group, and respiratory rate was also similar between these groups. And so we conclude that hemodynamic parameters and dyspnea were similar between groups with no changes observed, no real significant changes observed after immunization. So if you guys have any questions, let me know. And this is my contact information if you guys have any more questions as well. Oh, I'm so sorry.
The individuals that you studied had COVID and they were then vaccinated afterwards. Is that correct? Okay. So are there examples in which vaccination post for other types of infection, vaccination post-infection have results or consequences associated with those?
Just to clarify, you're asking like if we took a different, I guess, disease and we had a vaccine. So for that, I wouldn't be so sure. Maybe there is. It's kind of out of the scope of my knowledge. I think a good thing to realize from this data is that with the talk of vaccination and COVID, I think a lot of people may be scared or not sure the effects that it has on them. And so this kind of like to kind of address those concerns. Mm-hmm.
All right, good morning, everybody. My name is MacKenzie Carter. I am a graduate student in the Public Health Department, and my mentors for this project are Dr. Tishra Beeson, Dr. Amie Wojtyna, and Dr. Katarina Mucha. And it is titled Mixed Methods Exploration of COVID-19 Vaccination Status versus Influenza Vaccine Uptake. Okay, so just a little, I'm going to provide a little bit of background today, including how the health belief model can be used to look at vaccine decision-making, vaccine acceptance and inquisitiveness, and overall vaccine decision-making. Oh, should say health belief models and vaccines. So the health belief model is a health behavior theory or framework that looks at how people make decisions about their health. And in terms of vaccines, So modifying factors are individual characteristics such as ethnicity, education level, income that then impact your individual beliefs. So in the case of COVID-19 or influenza, it's looking at your perceived susceptibility or severity of contracting the disease. And perceived benefits or barriers to preventative action, which in this case is vaccination. So all of those factors then lead into the individual behavior, which is whether or not to receive a vaccination. A lot of people tend to view vaccine decision-making as two sides of a coin. People either accept it or they refuse it. And I think we need to reframe the conversation a little bit more to look at it as vaccine acceptance and inquisitiveness. It's much more of a spectrum of beliefs. So on one side here in the green, we have individuals who accept all vaccines with confidence. They trust and have faith in the systems. On the other end, we have individuals who refuse all vaccines with conviction or confidence. And then in the middle there, where a lot of people would say that these are hesitant individuals, I want to put in that they are inquisitive. They have questions and concerns. They want more information. And it's not necessarily saying that they will not receive it. But as you can see, there's a whole range of decisions that can be made within that. So as we saw in the health belief model, in that first column of modifying factors, there are a number of different influences in our environment and socially that impact how we make vaccine decisions. So one of the biggest factors that has been observed in influenza vaccination rates, as well as significantly in COVID-19 vaccinations, are decisions by race. So you see here in this chart from the CDC, looking at flu vaccination rates in adults according to race and ethnicity. So on the yellow bar across two different flu seasons, we see that the highest rate of acceptance is among white non-Hispanic adults. This has held very true for COVID-19 vaccinations as well. And then in the orange bar, again, the lowest across both seasons are Hispanic adults, which again, among influenza and COVID-19, we have much lower vaccination rates among people of color and minority groups. And then also differences by rurality. So individuals who live in urban areas versus rural areas across the United States have different vaccination rates. This has been seen a little bit more predominantly in COVID-19, and that difference, the gap between urban and rural residents has evened out a little bit, but residents of rural areas have faced higher cases, higher mortality rates, and lower vaccination rates throughout the COVID-19 pandemic. Okay, so for this study, I conducted a mixed methods approach. For the quantitative portion, I asked, are individuals who received a COVID-19 vaccine more likely to receive a flu shot in a typical year? And for the qualitative portion, I inquired, how do individuals make decisions about flu vaccines? So the data for the quantitative portion was pulled from the Kittitas County Public Health Department's COVID-19 Vaccine Attitudes and Beliefs Survey, which was conducted in September and October of 2021. And I performed a chi-square test to compare COVID-19 vaccination to receipt of a flu shot in a typical year. And then for the qualitative portion, I conducted 11 one-on-one interviews. My overall thesis study is looking at parental status as a modifying factor in COVID-19 vaccination status. So that just happened to be the population I worked with. These people were recruited from the overall quantitative survey as people who expressed interest in a follow-up interview. Okay, I realize these are tiny numbers, I apologize. So the demographics for the quantitative portion, just a couple things I wanted to point out. there are 581 participants included in this analysis. It is across both groups of, on the left, typically receives a flu shot versus typically does not receive a flu shot. Among both groups were predominantly female, about 3/4. Pretty even distribution across age ranges between the two groups, and slightly overrepresented in white participants. But the biggest things I wanted to note were have you received a COVID-19 vaccine? So we're going to go more into this on the next slide, but I think it's striking that 94% of those who say they typically receive a flu shot have received a COVID-19 vaccine. Even more striking is that it's a 50-50 split on those who don't receive a flu shot have not received or have received a COVID-19 vaccine. Okay, so here are the results of the chi-square test. So the question on the survey was, in a typical year, do you receive a flu shot compared to have you received a COVID-19 vaccine? The p-value implies that yes, there is a very strong significance between these two variables. And I think it's demonstrated a little bit more visually in this. So looking at the percentage of the survey respondents of these 581 participants. So 60% of them overall received a COVID-19 vaccine and typically receive a flu vaccine. And then again, that 50-50 split of individuals who do not receive a flu vaccine, half have received a COVID-19 vaccine and half have not. Okay, and the only thing I wanted to note on the demographics for the qualitative participants is that while all 11 have received a COVID-19 vaccine, thank you, only 8 have a consistent flu shot. Okay, I'm going to read one quote really quickly. These are pseudonyms. So Rose, a mother of 2 young children, said, I certainly as a young adult did not get flu vaccines. I really thought I was, I don't know, protected from it. So ridiculous. Like such a young person thing to think. And I didn't see the systemic reason for getting it. Once I started getting those flu vaccines before I was a parent, but definitely that has reinforced my need for it. I just see it as so important now. Kind of emphasizing what I've seen throughout this study is that individuals are not getting the flu vaccine or COVID-19 vaccine just as a protection for themselves, but also for the protection of those around them. Okay, so the majority of interviewees expressed a higher perceived benefits through confidence in vaccines and trust of healthcare providers, and lower perceived severity and susceptibility to influenza than they did for COVID-19 vaccine or COVID-19. Okay, so really briefly, people who received a COVID-19 vaccine are significantly more likely to have received a flu shot. And again, the 50-50 split in individuals who do not receive a flu shot typically. Brief limitations, since my variables are categorical, I only have a handful of tests to test for significance. And for the qualitative portion, it is a small sample size with fewer questions about influenza than COVID-19. And then implications. We need more research on why there is a split. Why did only half of the people who typically don't receive a flu shot get a COVID-19? What prompted them? Did they have a higher sense, a higher perceived severity or susceptibility, or did they have more perceived barriers to the vaccine? We need more outreach and education on overall vaccine safety and efficacy for influenza, COVID, routine pediatric vaccinations. And in line with vaccine inquisitive individuals, we need to create more opportunities for people to ask questions of trusted healthcare providers and trusted sources of information to help build confidence. Oh. Any questions? Thank you.
Were there any data that you had access to in this to identify access issues, healthcare access issues?
Yes, the overall survey did ask questions about if you have not received a COVID-19 vaccine, do you have the information you need in order to seek it out? The phrasing of it did not yield the results we were hoping for, and a lot of people just angrily replied, "I will never get the vaccine," or thinking that we were trying to poke them further. So we did ask, but we didn't quite get what we were looking for with that.
Hi, MacKenzie. Great job, and thank you so much for your presentation. I'm curious if you can talk a little bit about prior literature on vaccine decision-making, and if influenza vaccine typically, as you investigated here, is predictive of other types of vaccine decisions. Are your results consistent with prior literature?
So yes, one of the top indicators for people to receive a flu vaccine is if they've received it in the past. So that repeated confidence. The rest of your question was about just, yeah. So it's tracked with prior literature, and especially one of the studies on influenza vaccine uptake. For parents of children, talking about how the more education they had, the more likely they were to get their child and themselves vaccinated. So it's, again, increasing the perceived benefits and decreasing those perceived barriers. So yeah, it's been consistent with previous literature. Thank you. Thank you.